Welcome to a special episode of the Medicine and Science podcast from the BMJ. I'm Cameron Abbasi, Editor-in-Chief. The BMA has elected a new Chair of Council, and it's Tom Dolphin. We sat down with Tom to find out what he plans to bring to the BMA, how he'll bring the profession together, and the BMA's strategy for pay negotiations with the government. Rebecca Coombes, our Head of Journalism, talked to Tom. You can also watch this as a video interview on our YouTube channel.
So we're joined by the new chair of the British Medical Association, Dr. Tom Dolphin, who's a consultant anaesthetist and a long-standing trade union activist, and now the figure at the helm of the Doctors' Union during one of the most turbulent periods of NHS history. He takes over at a time of deep unrest in the profession, with resident doctors locked in a protracted industrial action, record levels of burnout, and a government promising reform but facing a broken system. So, Tom, your election marks a shift in tone and strategy within the BMA. And so really looking forward today to hearing about what you stand for. And so first of all, tell us about yourself a bit and how you think you epitomise that change.
I'm not sure there's going to be a huge change in direction. We've got a strategy for the BMA over the next couple of years, which has been agreed by Council and which we are following. And I was part of designing that, as everyone on Council was. I think it's more of a slight change in focus in that we've done a lot of the work to empower the union nationally, in the national pay campaigns particularly. And what the next piece of that work is going to be is making sure that members are empowered locally. So if there are issues that are relatively small or local, but still have an impact on individuals, rather than needing a national campaign about it, people need to be able to defend their terms and conditions and to make their working lives better and to stand up for themselves and their patients locally as well, in a way that sometimes people are a bit disempowered from doing at the moment.
So bringing the work of the union just closer to your membership.
Exactly. And a lot of trade unions have a very much more local approach, where branches, which is like the local structure in whatever the workplace is, are the centre of what the union does. And the BMA has been very much more centralised than that for a long time. And it's trying to not take away from the central activity that we're doing, but to add on to that the local work, so that it's going on already. Like, people are already doing this work. The local negotiating committees are doing this work. There are local reps. There are regional branch of practice committees, like the regional resident doctors committees, for example, that are doing this work locally to represent members, to run campaigns and so on. The thing is, they're doing it without necessarily getting a lot of support from the BMA. We're not stopping them from doing it. We're just not particularly facilitating it. And we need to have a lot more focus on training people up to fulfill those roles, to empower them so they know what their rights are, what their members' rights are, how to run a campaign effectively, how to find allies for your campaign, all that kind of thing, so that when they do this work, it's just more effective.
Mm-hmm. I mean, I have to say, you're quite young. You've never chaired, I think, a BMA committee, and it feels that there has felt recently there's sort of like an almost new generational voice that we're hearing within the union. And do you think do you feel part of that generation?
There's certainly a shift towards a much younger feel to council. I'm not that young. I'm almost 50. Thank you. But I have chaired a branch of practice committee before. I was chair of the junior doctors committee, as it was then, but that was many years ago, more than a decade ago. There has been a shift in council's average age shifting downwards, definitely. And I think that reflects the fact that the most recent council elections 3 years ago, there were a large number of resident doctors who were very angry and motivated about wanting the BMA to do something about pay, and they organised themselves and stood for election and got themselves elected, which has changed the dynamic of council for certain.
No, absolutely, and I think that's definitely, and we know as the doctors' vote movement has really energised a new generation of doctors. I suppose it's also drawn some criticism and some press criticism, allegations of extremism. I mean, how do you plan to ensure that all the voices across the profession are heard under your while you're at the helm?
I think the it's slightly overblown, the concern that people have about sort of radicalism within the BMA. It's not like that. What's happened is that the trade union side of the BMA had diminished in its effectiveness, and that's why we'd seen pay erosion, because the bargaining side of the trade union of the BMA had sort of lost some of its effectiveness. Obviously, like you can see that because our pay had declined in value, and the professional association side, all the other work that we do, had taken much more of a front seat. All that we've done really is rebalance that and try and get some more evenness in terms of the work that we do. To some extent, the professional association side and the trade union side are not separate things. They're different aspects of the association, the BMA. And they can complement each other in the sense that the professional association work that we do is an expression of doctors and medical students' desire to improve the world around them, improve the care that patients get, improve all sorts of things about the world. And the trade union side is more about doing that through the lens of the workplace and the conditions that people work in, and are there enough doctors in the system? Are they getting paid enough to retain them? Are they getting the rest that they need? And those things sort of merge into patient safety issues about rotas and about fatigue and so on. So these things, it's trying to draw a distinction between where the trade union work ends and the professional association stuff begins, I think is it's a spectrum rather than a clear dividing line.
Mm-hmm. I mean, you're bringing us nicely onto pay. And we can't not talk about pay today, especially as we're meeting the day after the residents' doctors' committee voted for 6 months of strike action in demand for 29% pay rise. Is this the wrong battle at the wrong time? I mean, less than 50% of eligible doctors voted in favour of strikes, and new polling out today shows that only 1 in 5 of the general public actually support the ongoing strikes. I think it was like 50% support last year. So what I want to ask you is, how do you win back public support? And also those doctors that didn't vote in favour, how do you bring them with you as well during the next 6 months?
I think the first thing to say is that the issue remains because we took an approach where we said we wanted our value to be restored to what it was in 2008. And that's why the campaign hasn't ended. We were given pay rises last year, which were the first step on that journey.
This
on
is
the
22%.
The various pay rises different. It was very different points on the pay scale, but yes. And that was supposed to be the first step on a journey towards reaching the point where our value had been restored, because we're not worth less now than we were in 2008. Like, the work that we do is not worth less. The effort that we put in is not less. So why should the pay be? And the reason the pay campaign is still going is because we haven't got there yet. And the understanding that we had last year was that this was going to be a step on that journey. That journey has come to a halt, and that's with the most recent pay awards that we've had, which barely cover inflation, certainly don't go any way to restoring the pay ahead above inflation. And so that's why the resident doctors have voted to strike again, because they're not getting that movement that they need to see from the Secretary of State. We've given him plenty of opportunity to negotiate to avoid us getting to this point, and he didn't take those opportunities. So the door remains open. We can avoid strikes if we get a good indication that we're actually going to continue that journey to pay restoration. And in terms of the public support, I think the public do understand that idea that our pay has dropped, and if anybody had a pay cut of 30% in value, they would want to do something about it. I think people understand that. It's partly because that narrative has moved out of the media, because we've moved on. The news has moved on to other topics since the strikes from last year, because other things have happened in the world, and people have forgotten that rationale. And once we go back to explain that rationale and saying, we're still down 22% on what our pay used to be, our pay is still more than a fifth less than it was. People will see that and understand it, I think.
Would you not think that the chance of you, getting your demands met are sort of receding with dwindling public support? Fewer of your members coming out in favour. I'm just wondering, will your approach to the negotiations as a new chair across different branches of practice differ from your predecessor? what, if anything, needs to change?
I think the turnout in the ballot needs to be taken in the context that we're comparing it to a literally record-setting turnout. One of the highest ever achieved in this country in terms of ballot turnout and the yes votes for strike. So this is more of a reversion to the mean than a sign necessarily that the campaign is not succeeding. So I'm not too worried about that diminution in the turnout.
I was interesting just talking about your personal approach to these negotiations. You're the new chair. That's something which is different this time round.
Yes.
What, if anything, might change about the way you approach this dispute?
For the pay negotiations within the BMA, we devolve the discussions about pay and the negotiations about pay almost all the time to the branch of practice committees and to the chairs of those committees. So the Resident Doctors Committee, have met with the Secretary of State to have those negotiations. The Chair of Council doesn't normally get involved in those negotiations at branch of practice level because that's their area of expertise. We'll let them get on with it. I've had a conversation with the Secretary of State where we talked about what the possibilities might be for resolution, and I was clear to him that our members need to see their pay restored and that they still feel strongly about this. It's not something that's gone away. And he put his position across, which you've heard in the news over the last couple of days. And we agreed that we would try and talk constructively. He's got people that he needs to... he has his position that he needs to hold. And we have our members that we need to represent, and it's trying to come to an accommodation where all of our needs can be met. The Secretary of State's political needs and our members' needs have to be met, and that finding that point in the middle is going to be difficult.
It's difficult, isn't it? Because as of today, he's saying we're not reopening negotiations. It seems fairly intractable.
Yes, and unfortunately, that is how we end up with strike action, is by intractability, by politicians who don't recognise the validity of the claim that we're making. It's, we've got a legitimate claim. The value of our pay has dropped, the value of the work hasn't. So why is this gap opened up? Why is he not trying to fill that? Why is he talking about valuing doctors and then not actually valuing them in any way that counts? They talk about non-pay elements to things, which is to say things that are not money. Could we do things about exception reporting? Could we do things about the way rotas are constructed? That work that was talked about last year as part of the deal just hasn't materialised yet, and it's been months and months and months of difficult discussions that don't progress, and that's on the supposedly relatively simple non-pay bits that are supposed to make up for the fact that we're not getting all of the pay restoration as quickly as we'd like it. If we're not seeing progress on those things, how can we expect to have those have additional non-pay things to make up for not getting the pay that we're asking for? It's not a reasonable request. So there has to be a pay element to it.
Okay. Well, I suspect we'll be returning to this again and again over the next 6 months. What I'd like to do now is go back to you a little bit. We haven't really talked much about you. You're a consultant anaesthetist. Maybe just tell us a little bit about that and where you work. But also, why did you decide to challenge Phil Banfield? And what do you believe you bring to the role that sets you apart?
I'm, as you say, a consultant anaesthetist. I work in London in a major trauma centre. So a lot of the work that I do is emergency work, lots of out-of-hours work. So it's very busy and full-on in terms of the clinical work that we do. The good thing about being an anaesthetist is that we're relatively flexible in terms of when we work and how we work. So that makes it relatively easy to do BMA things because I can come in and out as needed. I can swap with colleagues relatively easily. And one of the nice things about the role that I've now stepped into is that it allows a lot of time for doing BMA stuff. It allows all my time for doing BMA stuff. For many of our reps, they give up their evenings, they give up their weekends and clinical days and annual leave and trade union leave to do this work. So it's nice to be in a role that allows me to do that and to give it all the attention that the role needs.
But why you now? Why did you decide to stand at this point?
I stood at this point because I wanted to make sure that the work that Phil began, because Phil has done an amazing job. Like, he's taken charge 2-3 years ago and transformed the way that the union works. The council was behind him, and the rest of the associations behind him in terms of making that change that we talked about before, where we have much more of a focus on terms and conditions and particularly the pay restoration campaign. And to do that, there have to be lots of internal changes within the BMA in terms of how the resources are distributed, how the staff face members, how the staff interact with each other. All those things have to happen. And that was a huge piece of work that Phil took forward and did an amazing job. And we owe him a huge debt of gratitude because, we've seen big success in terms of progress on the pay campaign. That pay campaign now needs to continue. So my intention is to continue to bring that sense of momentum as we go forward so that we don't lose track of where we're aiming for this pay restoration piece. But there's also lots of other work that I want to do around the valuing of the profession in other ways, not just in terms of salary, but also in terms of the recognition and the deprofessionalisation that we've seen. There's a lot of things in the 10-year plan, for example, that suggest that we're trying to replace some of the work that doctors do with non-doctors, and that worries us a lot because people undervalue the benefit that you get from having the skills, the knowledge, the training, etc., all in one person. If you try and split things up and try and break down medicine into individual tasks, and give those tasks out to different people to do in a kind of chain line, assembly line of healthcare, that doesn't really work very well. The benefit you get from having all of that in one person, in the doctor, is immense in terms of the effectiveness, the productivity, the safety, the patient safety elements of it. And we seem to have moved as a country into a position where we don't value that anymore. And that kind of goes in line with the loss of value of the pay, because we're not valuing doctors, we're not seeing the value of them, so we don't want to pay them as much.
So you've touched on several flashpoints there, I think, that are facing the profession right now. And I just wanted to get your stance on a handful of these. So the first one is the BMA's legal challenge to the GMC over physician associates. What's your position on that?
Well, we've brought this legal challenge, and we've supported other organisations' legal challenge as well, because fundamentally we think the GMC's got it wrong on physicians' assistants and anaesthesia assistants as well, PAs and AAs. Fundamentally, they are being used, whatever the intention was, they're being used to replace doctors in various ways around the country. And we don't think that is good enough for patients. Patients deserve better. There's also the issue that patients don't always realise that they're not seeing a doctor because of the way that PAs and AAs are presented to them. And because of that, we think that patients are being misled, essentially, by the system into thinking that they're getting care that they're not from a doctor. The GMC should... we've got the Leng review coming out. It's been delayed, so we'll see when it comes. We don't know what's in it yet, but our hope and expectation is that it's going to do something to try and overcome this problem that we've got, where there's a growing cohort of people working in the NHS who are doing tasks and doing things that are beyond the scope of their training, that they're not actually trained to do. They're trained in something that looks like that, but is not anywhere near as deep, not anywhere near as broad. And as a consequence, they're being put onto doctors' rotas or given doctors jobs to do, tasks to do, that they're not doing as well, not doing to the standard that we expect and which patients should expect and which they deserve. So we're hoping that the Leng review is going to, first of all, address the perception issue with a name change to make it clear that physicians' assistants are there to assist physicians rather than to replace them. But also there needs to be a national scope of practice, a definition of what it is that PAs and AAs can do that's set nationally, perhaps by the Royal Colleges or perhaps by somebody else, but not set locally, because the risk of having it done locally by the employer saying, we've employed these people to do this work, and we're a bit short of, urology trainees, let's put them on that rota and they can do anything that a urology registrar can do, because we just defined the scope locally. We just say they can do those things. Evidently, that's not safe.
Yeah. Do you think the association's right then to concentrate some resources into this battle? Do you see it as one of the biggest challenges facing your profession at the moment?
It's a significant element of the deprofessionalisation of medicine in the UK, and it's also significant overseas. We know that other countries are looking to see what the UK does. They're looking at this experiment that we've, launched ourselves into.
Do you feel a sense of responsibility there then to get this right?
Absolutely. I think if we don't get it right, we'll end up with an NHS where the patients are getting two-tier care, because we know that there tends to be a concentration of PAs being used in areas that are less affluent than others, and that people in well-off areas get to see a doctor, and people who are in less well-off areas, you can see the PA. That's fine. And that's being driven by government policy. It's being driven by a lot of different factors. But one of the factors that's most important, I think, is the way that the GMC has facilitated and allowed these things to go on, and hasn't taken responsibility for who should set the scope, what the name should be, how PAs and AAs present themselves. And there's a group of people in there who don't need to be forgotten about as well, the PAs and the AAs themselves, who've been led into this profession understanding that they are going to be allowed to do this or that, but actually that was a false understanding. And they really should be assisted, I think. Clearly many of them would like to be doctors. They're doing jobs that are very similar to doctors in some ways. The government needs to take responsibility for what's going to happen to that group of people, and maybe find some way for them to apply to go into medical school if they meet the standards. But we can't forget that there are people in there as well.
Just about your stance on the NHS plan. It's very aspirational, but obviously the big issues there around workforce, digital innovation, GP reform. I think you've said in your response to this that the government's pledge for an extra 1,000 extra specialty training posts won't touch the sides. What, in your view, is truly needed to fix medical training? And are you confident that the new government can deliver?
The 10-year plan is sort of quite high level, as I'm sure you've seen. It sort of describes the outcome without really describing very well how we're going to get to the vision of the future. And as you say, the 1,000 training posts is nowhere near enough to deal with the problem. And there is the potential for sort of many thousands of doctors to find themselves either underemployed or unemployed, or certainly out of training in a very short time. And that's going to create a huge problem for the government, because they're going to have a large number of resident doctors who are not progressing in their training, who are not continuing on that pathway to becoming specialists that the system needs. They're going to be obviously increasingly angry about the situation that they're in. And we've seen where that goes before. We've seen this 15 years ago with MTAS and MMC, that large groups of resident doctors, when they're angry, can be a very powerful force that can be a real problem for the government. So they need to get a grip on that unemployment and underemployment issue so that it doesn't get to that stage. It's going to require much more radical intervention than 1,000 posts at some point over the next 3 years.
And talking about training, I just want to touch about international medical graduates, both their treatment and their integration into the system. We're going to see some changes coming up with regards to priority and training. What's your stance on international medical graduates and their place in the NHS? What needs to change?
We rely on international medical graduates in the NHS because we haven't got an adequate supply of doctors from the UK. So we do rely on them, and they are an integral part of the team. And they're also integral part of the BMA. We have thousands and thousands of members who are IMGs. And part of the unfortunate nature of the discussion over the last few months is that people have tried to pit international medical graduates against UK graduates, and as a zero-sum game. The problem here is not IMGs versus UK grads. It's why has the workforce system been allowed to set everybody up that they're competing for an inadequate number of training places? We know that we've got this number of people coming through. We know how many specialists we need in the future, and the number is only going to increase. How have we allowed the system to constrain training numbers, the NTNs available, to such a degree that we've got doctor fighting doctor for these posts. It's completely the wrong way round. We should have enough training posts for the people who are coming through, because we know we're going to need them as specialists later. And if they leave the UK, if the UK graduates leave the UK because they can't get into training here and they want very reasonably to progress in their careers, they're going to go to Australia or Canada or wherever it is, partly about the pay, but also partly about the ability to progress to the specialist role as a consultant or the equivalent in that other country, then that's a loss to the NHS. We spent all this time and money putting them through medical school, which they pay huge fees for themselves, but the system also pays quite a lot towards that. And then the money spent training them, and then they leave because they can't progress because of a workforce planning failure. It's ridiculous. It needs to be gotten a grip of. And we've seen it as well in the growth of the non-training training programs that are sort of springing up all around the country, where locally various hospitals have banded together to set up rotations in effect for locally employed doctors, LEDs, where they rotate between the different hospitals on various contracts. It looks like a training program, but it's not funded by the government. It's not included in the workforce plans. Plans is a strong word for it, but the attempts at planning that have been made and have clearly failed, but they're not included in those. And they don't have the oversight of that. Many of them are perfectly good quality programs, and they get good training in those hospitals, but there's no oversight of them in the way that training programs do from the deaneries and so on. So these are all symptoms of a failure of workforce planning, which is causing huge problems for the profession and for the NHS, because we're going to struggle with the workforce being unbalanced in a few years' time if we don't get a grip. But that requires investment. It requires investment in terms of training programs that people can get into. It requires investment in terms of the pay element to retain people so that they don't just leave with their qualifications. And it requires investment in valuing people in the workplace in terms of how they're treated whilst they're at work. Not just the pay, but all the other things, rotas and leave and study leave and all of those things. It's all part of the same picture of deprofessionalisation and undervaluing doctors that I'm hoping, it's my intention to drive forward in my time in office.
Thank you. Just that's great. Another flashpoint is we live in divisive times, don't we? Polarised opinions, and the BMA is not immune to that.
No.
As we saw at this year's ARM, there were allegations of anti-Semitism, and that's an example of where members can become quite polarised and the debate can get quite toxic. How can you help unite the profession around these kind of touchstone issues?
The first thing to say is, of course, anti-Semitism has no place in the BMA, and it has no place in wider society. And we don't tolerate it. And where there are allegations made of anti-Semitism, we investigate. We, take disciplinary action as needed. The profession has it's become a cliche in politics, but there is more that unites us than we have more in common than divides us. And that's true of medicine as well. I think the key is to remind people that we are not opposed to each other, that we're actually fundamentally all on the same side as a profession. We all want the same things. We want our patients to be well looked after. We want to, sort of have a decent quality of life and work-life balance. And we want our profession to grow and flourish. And when people are reminded of those shared values, which we do see also at the annual representative meeting, the ARM, we see people coming together, and you can feel it in the room. For some of the discussions, you're like, yes, everybody's on the same side on this issue. We all see that the profession wants the same things on this, and that is very empowering for people who go to those meetings to sort of understand that they're not alone. I think people in the workplace sometimes feel a bit isolated, like they're the only person that feels that way. And then the power of a trade union, of course, is that it brings people together and they can amplify their voices on the things they hold in common. And part of the role of the chair of council, when those debates get difficult, when people have strongly polarised views, is trying to get people to actually hear each other. Because a large part of the problem, I think, is that people, it's not that they're not listening, it's that their frameworks for thinking about things are so different that there's actually very little in the way of shared understanding of the common reality of an issue. So you've got to try and get people to the point where they can actually have some shared understanding of the facts about a matter, the truth of a matter, so that you can then start to deal with how do we address the future going forward. Because if you don't agree on the present, you can't get to a future together.
If I may, I just talk about one last decisive issue, which is, I mean, you've spoken out against the Cass Review, which is the review that dealt with gender services for children and young people in England, and you called its rejection one of many steps needed. I mean, what further steps do you believe the BMA should take now, and how do you respond to those within the membership that feel alienated by this stance?
It's important to recognise that trans people are one of the most marginalised groups in our society. They've been subjected to a relentless barrage of attacks in the media, in social media, and now also from politicians in terms of things that are being said and done about their rights. And people are just trying to live their lives, right? Trans people just want to live their lives like anybody else. And their existence is being called into question. Their rights to move in the world, their rights to, just use a toilet are being called into question every day. And that's incredibly distressing for them. And that's one of the reasons that I am proud to support trans rights, because I think that people deserve fundamental human rights. They deserve to be treated as humans and to be included in society. And at the moment, that's not what's happening to them. They're not being treated in the way they should be. The BMA, as you know, is doing its review of Cass and the methodology that the Cass report followed. That's ongoing and will be coming out soon. I'm having no part in that. It's got to be independent of me. I'm staying very clear of that because it needs to be done. That group is doing its work, and we'll finish that. And again, sorry.
At the heart of this is evidence-based health services, and I'm wondering, what would you What would you do? What kind of health services do you think we should be providing in England at the moment?
One of the things that was so distressing for trans people was that the government's recommendations and the actions they took after the Cass report kind of went far beyond what was in Cass's actual report. For example, the ban on puberty blockers, just a universal ban across the country, and the criminalisation of people trying to get the puberty blockers brought in, imported from elsewhere. That was far beyond what Cass had actually recommended as an example of not non-evidence-based healthcare. And we've seen the same thing with the Supreme Court ruling about the very precise definition of a woman within the meaning of the Equality Act 2010. And then the guidance that has come out since then from the AHRC and others has gone far beyond that, way beyond what the actual ruling said. And in both cases, it feels for trans people as though the slightest opportunity is being taken to give them a hard time and to make life more difficult for them. Trans people need to be able to have access to healthcare, not only for their gender affirming care, the hormonal treatments they need and the monitoring and so on that goes with that, but also just to be able to be respected in the healthcare system, to not be othered. There've been talk about having trans wards for them to go to. It's a terrible idea having this sort of special third place that trans people get put into. It's an awful idea and very dehumanizing for them. And they deserve not just the gender affirming care, but also, as I say, for the NHS and other providers of healthcare to treat them as human beings and to treat them with respect and dignity.
But it sounds like you think the ban on puberty blockers was outside of research centre was an overreaction.
It went beyond what Cass had recommended.
Okay, thank you. At the end of your term, what would success look like for you? Both for the BMA and for the profession more widely. You've got 3 years ahead of you now, I believe.
Success would look for me like the union being as strong in the workplace as it is nationally in terms of achieving wins for its members, for the members themselves to win in the workplace and nationally as well on pay, on the deprofessionalisation agenda I've been talking about, all of those things, so that we have a profession that is respected and valued and is able to provide the care that what we want to do. That's what doctors want to do. They get up in the morning, they want to go to work and look after patients and not have to worry about all the other things that we've been talking about. They just want to be able to provide good quality care in a functioning NHS that has the resources that it needs, that has the staff that it needs to be able to progress and to be able to get patients what they need and for people to be happy in their work while they're doing that.
Great. Tom, thank you very much for coming to see us.
Thank you.
And we'll be back next time with a regular episode of the Medicine Science Podcast. You can read Tom's interview online on bmj.com. I'm Cameron Abbasi. Thanks for listening.